Dr. Jim Hernandez is our next speaker. He's a native of Pueblo, Colorado, which he's very proud of and speaks a lot of his days in Colorado. He graduated from medical school at the University of Colorado Health System, did his residency in anatomic and clinical pathology at St. Luke's Hospital in Denver, so a lot of time spent in Colorado. He then came to Minnesota in community practice, and following that was the chair of the Division of Clinical Core Lab Services, my division, our division, from 2005 to 2008. And that's where I met Jim, and again, he was my division chair for 3 years. Has been a wonderful friend, mentor, and a great leader in our practice at Mayo Clinic. Jim went on to complete advanced studies in Master of Science in Preventive Medicine and Administrative Medicine, and with that background, his area of interest has been in leadership and management, in safety and quality and outcomes and utilization. And he is really sort of a pioneer in many of these areas and a very thoughtful and inspiring speaker on these topics. Jim started the Leadership and Management course for our residents and fellows, which I had the honor of taking over when Jim left to do what he's been doing now since 2008, which is the head of our clinical labs at Mayo Clinic, Arizona. And again, in many opportunities, talking to people across the fields of laboratory medicine about quality, safety, utilization, outcomes. And it's a great honor to introduce him for our first talk this morning on safety in healthcare, the role of teamwork, just culture, and crew resource management.
Thank you very much, Dr. Karen. I'm really delighted, and I was so happy to be instrumental in hiring Dr. Karen to come here. And those of you who have interacted with Dr. Karen know what a superb pathologist he is and how much he's contributed. So these are some of my Rochester people from Clinical Core Lab Services that I have such great affection for. These are my Arizona people over here that I have great affection for. But everybody here is in phlebotomy and processing. Before I say anything, I want to let you know what you do is so important. And I want you to know that you're the face, you're the ears, you're the eyes, you're the hands. And we just don't hire a set of hands. So you're really, really important to the entire operation. A lot of times when people come to the laboratory, they only see you. And that's why there are no unimportant positions. Your position is so critical to healthcare. You take care of the patient. So before I tell you anything else, that's the most important message I have for every single one of you, that you have a very important position in healthcare, and please be proud of what you do, and you've got my support. We used to have people come to Rochester, and is Randy Grokey here? Randy, are you? Randy left the room. Randy, I see you. So, you know, I used to meet with every single phlebotomist when I was in Rochester, and what I would do is I would say, well, here's the deal. If you just follow the standard operating procedure, have good technical skills, draw the patients well, and we will have good success. If you have an idea, please let your supervisor know. And that happens because some of you are really innovative and you have good ideas. We want to hear those ideas. Bring those to your supervisors, managers, and your directors. So that is really important. I said, here's the deal. You go ahead and you follow that procedure. But if anybody is harassing you, if anybody is, in a sense, bullying you, whether it's attending staff or nurses or residents or fellows, I'll take care of it. I've got your back. I've got your 6 o'clock. So I said, and this is what happened here. We'd get these messages, and I'd call up the doctor and I'd say, what happened here? And I'd really, in a sense, go through the process and make them apologize to the phlebotomist. And Randy, what percentage of the time did we get the residents, fellows, attending doctors, or nurses to apologize to our phlebotomists? 100%, 100%, 100%, and we still do that in Arizona. Same thing, Janelle? 100%. So I think if you go home, tell your directors, you know, please have our back, because we're doing the best we can. It can be very stressful in what we're doing and just have our back. As long as you have our back, we'll do the very best we can for you and the patient. So just go home and tell your directors that. So I'm going to go over some things that Dr. Karen told you about, safety, as well as the role of teamwork, the just culture, and crew resource management. It's going to be a fun presentation. Who is living the dream right now? I love it, living the dream, because you want to live the dream. You know, good morning, Rochester. Remember what Dr. Sood said. You have to have gratitude. Yeah, there's 3 things I want you to remember. It's not in the presentation, but it's for you, for your life. One is perspective, one is perception, and one is the meaning you give things. And think about what Dr. Sood said. Do you all like his talk? Yeah, a lot of things to think about, really deep things. But their perspective is where you're looking at it. You know, I take a walk every morning, and I walk around the beautiful Arizona, and then sometimes I go this way, I'm walking this way, and sometimes I change and I completely go a different direction and I go this way so I can see things from a different perspective. So I have a new perspective, and I want to see the perception too. Things look different. The sun's coming on that building a little bit different. I didn't notice it. Some things I never noticed, so the perception is good. But the meaning is really important. Sometimes you're ever in a situation where somebody tells you something and you're really not very happy about what they said. And it's the stories we tell ourselves. Well, exactly what Dr. Sood said. So what I do every morning, I learned this from a colleague, and it's a thing called mudita. Has anybody ever heard of mudita? It's from the ancient Pali language, Indian language, and it's roughly translated as vicarious joy in somebody else's wins. And so every morning I say hello. And sometimes people look at me, they're startled like, why are you saying hello to me? You don't know me. So I say hello to everybody because I don't know, maybe I'm the only one that said hello to them. And if I see somebody, their shoulders are humped, and I say, well, maybe they just have a sick child, maybe they just get hit, maybe they ran out of gas, maybe they've got so many things on their mind, it's really, really hard to be able to come into work. So we've got to watch each other. We've got to, our own CEO, Dr. Noseworthy, says we've got 3 tasks. We want to take care of ourselves, take care of each other, and take care of the patients. So we just can't take care of ourselves. We need to do good things for that, but we have to take care of each other because look, there's a lot of us, and we're living in essentially a submarine. We don't get a lot of positive feedback, and I'll tell you a story. I don't get a lot of positive feedback either until I'm ready to retire. Then they say, hey, you really did a good job, Jim. When I was retiring from my practice in St. Cloud, coming to Rochester, the urologist said, well, he never gave me positive feedback, but he said, you really do a good job, Jim. He said, and you never made any mistakes. And I thought, whoa, he was counting. He was counting. So let's have some fun here. I don't have anything to disclose. And I just wanted to talk about the importance of developing strong teams, because this is what this is all about, and principles of what we call the just culture to learn from errors. One of the hardest things to learn, and describe a couple of tools called crew resource management and SBAR. Has anybody heard of the just culture? Let's see so about half people. What about crew resource management? Has anybody heard of that? Twilight, what about SBAR? Do you use SBAR in your areas? Who uses SBAR in your areas? Do your nurses use SBAR? Okay, so let's go through some of these things. These are my favorite Naval Safety Center quotes, and I like to think of us as different ships in the same fleet. So we're really kind of the different ships, and this is why I want to show this example of the naval example. Don't fix a blame, fix a problem. If you mess up, fess up. Just have honesty. And mama, don't raise no fool. I use PPE, patient protective equipment, to stay cool. Staying accident-free everywhere, safe, and you get the level of safety that you're prepared to walk past. Did you ever see anything that was unsafe, something that was on the floor, and you think, oh, somebody will take care of that? So I was walking down the hallway here in Rochester, and there was a tissue on the floor. And I picked it up, and I disposed of it. use the lotion to wash my hands. There was a patient in back of me. She said, I never saw a physician do that, pick up something. It's people are watching. What are you prepared to walk past? Because that's the safety, and that we're all safety officers. So how the heck did this happen? I'd like to have some interaction. Give me the story here. Somebody tell me a story of what happened here. He was going too fast. Exactly. What else about him? He was going. You said he. It wasn't a she though. But he was going too fast. What else? Tell me another story. Not paying attention. Yes.
And the boat got out of his control and hydroplane.
Yes. Okay. You think anything else was involved? Oh, alcohol. Whoa, well, looks like it's morning. So somebody was drinking He could have been on his phone. Yeah. He was distracted. What else could have been happening here? You tell yourselves a story. Remember I said perception, perspective, and meaning. You tell yourselves a story. What happened here? Maybe the boat went in front of anybody else. How about this side of the room? What happened to this guy? He could have had a heart attack. Good, Todd. What else? What else could have happened here? Anything else? Any other ideas? I'm sorry? Motor malfunction. Do you think he was rooting for the Packers or the Vikings and they lost? And he got mad? Well, maybe that was one of it. So it could have been any of those things, but there was an accident. They'll have to investigate. I wanted to show you some similarities between ships because ships are, they have a lot of people, especially the aircraft carriers. My own nephew's in the Navy. He's on a ship. He's always around Japan and other areas. And they take real young people, 18, 19, 20, and they train them very well. And they train them to do their tasks. And that's why I want to use the big ships as an example, because in this example, ships are what we call complex. There's a lot of stuff that can go wrong. And on the ships, it's tightly coupled. If the sailors don't figure out what was wrong, something can happen. Remember, there were some accidents around Japan just recently. You're all aware of those? And there were several accidents. So then they have to figure out what happened. It relies on teamwork and good communication. What happens when we don't particularly like somebody? Is it easy to communicate with that person? What's the first thing we want to do? Avoid them. So this is a mark of a professional. Even the people that we don't particularly like to talk to, we have to still communicate with them. Otherwise, that link is broken. I'll say, well, I'm not going to talk to Jim. He's always throwing me shade. So you have to get past that and say, this is good communication. Relies on situational awareness. Like I remember when I was a medical student and I was scrubbing in with a surgeon and there was some, the colon had become dehisced and there was some stool that was coming out outside the operating area. And I told the surgeon, there's a problem there. And he says, thank you very much for telling me because we didn't want that to happen. So somebody that may not be primarily responsible for that could see something bad. So you have to always be aware. And then they have many, many years of doing this, but phlebotomy is the same thing. We're real complex, right? You get called and you have a lot of really difficult patients and it's tightly coupled. You don't have a lot of time to recover. ED, ORs, intensive care relies on good teamwork, and you always have to have situational awareness. But we only have a few years of formally using safety tools. I hope I can convince you if we use these things from other areas, we don't have to reinvent the wheel. So what safety tools can we use from other fields? Well, the just culture is one of the very, very hardest things. What's hard for people? Give me an example of what's hard. Shout it out. I'm sorry? I'm sorry? Change. Change is hard. What else is hard? Specifically. I'm sorry? Upset patients is hard. How about in their personal life? What's hard? Life is hard. It's stressful. Losing weight for me, that's hard. Now, what else is hard? What other things are hard? Admitting you failed. Great example. Thank you for that. You know, this is really hard, just culture. Let me just give you something before I talk about it. So what happens every time we see TV and something happens, and in our litigious society, what do they say? What do they say? The announcers get on and other people get on. What do they say? They say, who's the guilty party? We want to find out who made the mistake. That's the legal way of doing it. This is completely different. This is almost Zen-like. Safety culture, just culture. But what have we been trained in the laboratory? If there's a mistake, we say, I know who did that. Jim did that. He's never paying attention. So that's what we always think. So we automatically think, and we start telling ourselves our stories, who made the mistake. In the just culture, then let me show you, it's completely different. So there's 3 duties, and that's the duty to avoid causing unjustified harm, the duty to produce an outcome, and the duty to follow a procedural rule. And the organizational values are safety, cost effectiveness, equity, and dignity, because we want to treat people with respect when this happens. But let me give you some examples to make it real. Here's 3 types of error, and I'll use myself of these 3 types of error. The 3 types of error are human error, a slip, a lapse, or a mistake. And the second one is at-risk behavior, and the third one is reckless behavior. So the first one is a slip or lapse. Can anybody give me an example of a recent slip or lapse that you've had where no one got hurt? Yes? Wrong tube, exactly. Can somebody else make that mistake? Oh, yeah. Somebody else can make that mistake. Very important. Hold that thought. What else is a slip or a lapse in your work site or outside? What's a slip or a lapse? Anybody? I'm sorry? A missed order. Yes, that can happen. A missed order. Even things that people think, and it's not according to the degree, that can still be a slip or a lapse. If nobody intended it, that's the whole thing. Nobody intended. No, how many people in your area come to work intending to make a mistake? I don't know. I hope we don't have any. Otherwise, they would be pretty bad. But we don't have. I don't think you have people in your area that come to your laboratory saying, "I think I'm going to make a mistake today. I'm going to make a real good one." So what you're going to do, and let me give an example. I'm driving in Arizona. They drive a lot faster, and it's very, isn't it right? It's driving a lot faster. So in the time of the snowbirds, when good folks like you come to Arizona, the snowbirds, there's 2 kinds of drivers. Some are really, really, really slow, and they're like, does anybody remember Mr. Magoo? And others think, I'm in Arizona, I'm going to drive like NASCAR. And I'm going to get in really close to somebody, and I don't ever have to signal. And in Arizona, we don't save energy, and that includes we don't signal. And that's our idea of not saving energy. We don't want to, stress that light bulb. So we're driving real fast, and we're driving real slow, so it's not always safe. So if I'm going from Scottsdale, which is half hour, to Phoenix to really go to the hospital, and I'm doing something as far as listening to music, and I'm coming, and all of a sudden I miss the turn, and I'm all the way up going towards Sedona, and people think, where'd Dr. Hernandez go? I thought I was supposed to be here half an hour ago. I zoned out. So is that, in your category, is that a slip or lapse or mistake, or is that at-risk behavior or risky behavior? Who votes for a mistake? Who votes for at-risk? And who votes for reckless? Reckless. So this is the distinction. If I just zone out, I never intended to miss the cutoff, but I just wasn't paying attention. That's by definition a slip or lapse. And the others, at risk and reckless, are choices. So let me give you an example here. You want to manage a human error by consoling somebody. You know, when somebody makes a mistake, and the first thing we want to say is, what were you thinking? But human error says, and this is what's really hard, you want to tell somebody, that must have been really hard. Were you really had a lot of things on your mind? What was going on? We've talked to people and they said, yeah, I had a sick child. I mean, I'm sorry, but that was a slip. So we have to look at processes, procedures, training, and design. Because you had mentioned something, somebody can make a mistake, but somebody else can make the same mistake. So if I'm the director and you're the phlebotomy supervisor or the phlebotomist, who is responsible for fixing that system? You or me? Me. I'm the blunt end. I look kind of blunt, don't I? But you're sharp. You look sharp. That's the sharp end. Most of you are sharp unless you're management, phlebotomy managers. So it's on the blunt end. So here's the magic of it. The sharp end people aren't at fault. They need to be consoled if they didn't make the choice. And that's the big if they didn't make that choice. Let me go to this one as an example. A non-cognitive error. A phlebotomist draws 3 tubes and one is the wrong tube. The other tubes are the correct type. Is this an example of a system problem? Yes. What kind of system problem is that? Can that be fixed in your environment? How would you fix it? Training? What else? What else would you do besides training? See it a little louder? Competencies, training, competencies, and making sure the right tubes are out there. Because if it's so confusing, they can do the wrong thing. We want to make sure that they don't. So let's look at this one. This is different. This is not when I zoned out and missed the cutoff. This is, I'm driving fast on the highway, and I got to tell you a secret. We can go 74 miles an hour if it's 65, and they won't catch us. We know that, right? We know that, Arizonans. We all do it. Why do I do it? Well, because Janelle's doing it. So we know we're not going to drive 75, but I tell you, it was a culture shock when I went from Minnesota driving 55 to Arizona. You drive 65, but that's kind of in quotations. It's really 74. And you try not to drive with Janelle or Shilly. She's the one that's driving 85. Is that you, Shilly's?
I have no comment.
And she has no comment. But everybody's driving this fast, and we're driving fast. But we made a choice because I chose to drive over the speed limit, 65. I'm driving 74, but I know I'm not going to get caught if I keep it around 74, because other people are going 80. So that's an at-risk behavior. So if I get a ticket, what should I tell my wife? Shalice was doing it. No, that's not going to cut it. I'm going to have to say, no, that's an at-risk behavior. I chose to do that. So you have to remind people. We had those speed cameras. Do you have speed cameras in your area? We have them at the intersections, but they took them away in Arizona. Why did they take them away in Arizona? People were not happy that they were getting caught. They said, take that, I think it was called Red Line. Take the Red Line company out because we like to speed. So they actually said, no, we can't do that. And that's something we have to really be aware of because that's a choice. So we have to increase situational awareness. How do they increase situational awareness? The state patrol or the sheriff's deputy just sits by the side of the road. That increases my situational awareness. It's like, whoa, there's a Smoky up there. I'm going to go 65. And we never speed through the school zones. It's just on the highway. How about an example of an at-risk behavior for us? Phlebotomist is in a hurry and doesn't follow the correct protocol for cleansing the skin before drawing blood from the antecubital fossa. So what do you think the proper response if you're the phlebotomy supervisor should be? What would you do? Coach? Yeah. Would anybody punish that person? Very good. It depends on if it's a repeat. But let's say in most times, if you sit down with the person and say, help me understand what was happening. And they said, well, I had a lot of people in waiting area, and I did this, and I didn't really, I know I cut corners. Yeah, I'm right. I was wrong. So you're right to tell me I need to pay more attention to my antiseptic technique. So they knew it. It was a first occurrence. So that is coaching. You want to coach them. What about this one, reckless behavior? This is the one where I'm going 85 on the highway. No excuses, no excuses. When I get a ticket, I can't blame Shalise or Janelle. I can't blame Dana. I got to say, hey, this is on me. 85, 90. That's reckless behavior. That's remedial action. That deserves punishment, regardless. And here's an example of reckless behavior. A phlebotomist uncaps a needle with a syringe and then sticks the uncapped needle in a cork board before drawing the patient. What is going on here? She's done this before and claims her technique is flawless. So where would you put this person in your organization? On the curb, yeah. Yeah, there's no place, because that's a judgment, right? What were they thinking? What were they thinking? So is there ever any, do you give them a big hug? A Barney hug? No way. Do you say, well, yeah, I've seen that happen a lot of times. No way. That is like on the curb. So that is who votes for punish? Yep, that would be, you got to do something, because remember, we're protecting the patient. Okay, so the just culture creates a structure to address errors, lets us learn from our errors, and near misses, which are really important, helps us to hold each other accountable, makes the system safer, manages behavioral choices. So it's not risk management, and it's not a way to ignore unsafe behaviors. I think in the past, this got the reputation of saying, oh, you know, if you're not going to get the guilty party, then you're letting them off the hook. Now, what we're doing is doing very similar to what they do in ships and in airlines. And you know how safe airlines are. Maybe they have us really cramped in our seats, but they've got a really safe record. They are very, very safe because they've had to go through these, especially in cultures where in the past where the pilot couldn't talk to the co-pilot because the co-pilot saw the pilot as a god and couldn't question anything about that pilot. They don't do that anymore. They have to be able to say, we're going to address this. So that's what they do in the pilots. These are 7 key questions. So for those of you in phlebotomy management, phlebotomy and processing, this makes the system safe. So if you say, ask these 7 questions, you know, it's the first thing, you know, like what Dr. Sood was saying, you want to go from the prefrontal down to your reptilian brain, and you want to take that bat and just bomb somebody on the head. You say, oh, you made me look bad, you damaged the patient, but make sure you go through this because it could be a blunt end issue. Does the person know about the rule? And was the rule reasonable? And was a thorough investigation done? And was there reasonable proof of violation? And was the rule consistently and fairly applied? And was a corrective action appropriate? And progressive action when it's not appropriate. And you have to give people a chance to improve. Because remember, we hired these people. We want to make sure that we coach them up and they can get to that area that's good. I know my friend, Dr. Mike Anstiad at Seattle Children's, he taught me that you have these 4 boxes. You have somebody that's not very good, and you can coach them up to average. And average, you can coach to above average, and above average, you can coach to really great. You're not going to get the people that are below average to great. So when you're hiring, you want to be careful to at least get average, because you can coach up average to above average and above average to good and great. So that's the key thing. Who judges the judgment of people? Is that in your protocols? Does anybody have any protocol that says, this person has a bad judgment, so we'll let him go? Who judges that? Anybody have any ideas? So I would say it's everybody's responsible for judgment. If you see something in your area and it really troubles you, judgment is really important to bring up. I think it's a brave phlebotomist processor that brings it to the director, the manager, the supervisor's attention. I'm concerned about this person. So the person who stuck the needle in the cork board, somebody brought it to our attention because they said that's not safe behavior, and they were absolutely right. So that's what we want to be able to do. Now this is a little bit hard to see from the back, so let me walk you through this. This is the just culture process, and let me show you this. You start here, it's like a game. Was the job understood? Nope, I didn't understand it. Pass the substitution test. The substitution test would a similarly trained person be able to do this? No. So was defective training? Yeah, we think there was. History of violating procedures? No. So there's no blame. There's no blame. We missed something here. We didn't train them appropriately. They didn't really understand. You know, sometimes people shake their heads when they say yes, but there's different kinds of learning. I mean, I'm terrible at directions. If you can tell me directions, and ask Dr. Adamski, she'll tell you I'm terrible at directions. I need a map. I'd like this, you know, on my cell phone, you know, when I find my car, I say, where did I park when I came to spring training so I can find my car? How do I get over to Guggenheim from here? And so if I don't have to walk outside. So I think if somebody tells you verbally, the person you're talking to may not understand. They may need a graph. They may need some other way to communicate that they clearly understand the directions. So that's what's really important. This is, if we go down here, if we say, was the job understood? Yes. Was the action as intended? No. Knowingly violated procedures? No. Are the procedures clear? No. Or yes, then that's a reckless violation. So you see that comes down here on the just culture. We call it a just and fair culture in our organization. Notice here that most of the things are green, no blame errors, documented for the purpose of accident. Other people, well-trained, can make a similar error, so we've got to fix our system. And that's on the blunt end people like me. A negligent error would be maybe at risk. First written warning, coaching, increased supervision until the behavior is corrected. If it's really severe, like I told you, the person who stuck that thing in the corkboard, that's severe. So and that can happen in any good system because you don't know what's inside somebody's head. Somebody could come to work and say, I'm going to do this, and you find out later. But a lot of times it's the coworkers who can observe this behavior and say, you know, Jim, I'm really concerned about Joe. He doesn't seem right. So this is what I mentioned. The laboratory, most of you are the sharp end. I'm the blunt end. These are supervisors, lab managers, directors. We're responsible for making sure the system is safe. But we rely on you to look at that, the errors. And if you look for risk around you to protect yourself and report errors and safety hazards, and you want to make suggestions to your supervisors and make safe choices, a lot of this is role modeling. So if you're really good, you're safe, you give a good example, that's what you want to do. Anybody have any questions about the just culture? Does this make sense, how we'd approach this? Do you think you'd be able to take it back to your, yes, please.
You know, we use the just culture.
Yes.
And, you know, I still find that even though, like, we just report them as an error.
Yes.
And share them with the staff, like, what happened. But yet we still get a lot of feedback of, well, how come you're penalizing me for this? Because they still feel, because it was written down, because you're making them aware of it, that they're in trouble, even though nothing ever happened.
Yes. Yes.
Lots of people doing this.
Correct.
They still see it as punitive, even though it's in that green section.
You know, I would say you almost imagine like the scales, and one is holding people accountable, so the system is safe, and the other is protecting them too. So you want to make sure they're not unduly punished, but that if they have even a lapse or slip, that is recorded. Because if I keep missing the cutoff to the hospital, you know, then Dr. Dempsey's going to have to get me checked out because she's worried about me. But if it was one time, then that's a different issue. But it has to be, we hold people accountable and we look at the specifics and we try to determine the intent of their actions and if they have a history. And following that is actually very good, but it is really, really hard because what happens, people go back and say, oh, I think I know who did this. This was Jim. He's always zoned out. That's the easy out, like the legal type way. This is harder because it takes a lot of time. And if we build this safer and safer system incrementally, eventually you'll have a really safe system. And when you and your family members go in, remember, we're all going to be patients eventually. You can say, oh, I know that system is safe. I helped build it. And you're going to help build these systems. Great question. Other questions or comments about the just culture? Well, let's go on to crew resource management. My friend, Dr. Mike Castian, uses this. Crew resource management is a system of using briefs and debriefs. It's really a huddles is what this amounts to. And it was developed by the industry, airline industry, NASA, and the Department of Defense. And the body of work is scientific analysis based on human factors analysis. And there's extensive work in these non-healthcare fields, but why reinvent the wheel? You know, the sad thing here for anesthesiologists, they're the first ones to embrace it, but why did they embrace it? Well, I remember when I was a resident in Denver, they would have people that died from anesthesia, but what had happened? They'd hooked up the wrong tube to the oxygen. So instead of, you know, the patient was under anesthesia, and instead of getting oxygen, they were getting nitrogen, and they never woke up. So the anesthesiologists were some of the first to say, we have to figure out a system to make it safe, so we never hook up nitrogen to the oxygen port. So they're some of the first ones to embrace this. And the factor was coined, the human factors analysis, is based on James Reason's Swiss cheese. Does anybody know about the Swiss cheese model? Anybody know? Yes. I'm going to take you through the Swiss cheese. Does anybody like Swiss cheese? No, some people don't like Swiss cheese. I'm sorry for those of you who don't like Swiss cheese. It's got to be Swiss cheese. So doesn't this look like Swiss cheese? It's yellow. So the Reason model, James Reason, says, you know, there's a lot of things that have to happen if you're going to have a mishap. Let's say you have the so-called latent failures, organizational influences. Maybe you have a really mean boss who doesn't, who's on your back all the time. You have unsafe supervision. Your supervisor is wrong all the time. You have a history of ignoring things in your area. And then you have an active failure. So if all these things line up, that's why we call it, then you can have a mishap. In the airline industry, it could be a mishap for here. In our industry, it could be harm to a patient. So we have to do things really by the book for a lot of things. What happens if we don't identify a patient well or correctly? Is there a technological way to identify a patient? I mean, even when you're just looking at me and I'm the patient, how do you identify me and know that I'm me? Two identifiers, my name and my birth date. What happens if you don't do that?
You can have the wrong patient. I will also ask you to spell your name because you can have the same name as somebody else.
Yes. You have a good system, so you can have the same name as somebody else. You have to be 100% sure that I'm telling you who I think who I tell you I am. So if you don't do that, what happens?
You can have information for the wrong patient, and you can be treated for something that's not.
You can be treating the wrong patient. What do we call that in the blood bank? Wrong blood in tube. And that's why, you know, the nurses are really, really good at this. They always ask this information, and this is really a never event. It has to be, we have to ask the people their name and date of birth and at least two identifiers, because there's no way, it's not RFID, soft ID, nothing can get it, because that first step has got to be, you have to make sure that happens 100% of the time. Because downstream in the lab, in the blood bank, chemistry, microbiology, they're blind. So we really are the only line to make sure that that patient's addressed, is identified correctly. Why wouldn't somebody do that? Can somebody give me a reason why somebody wouldn't use two identifiers? You don't have to say their name, but from your own organization, why haven't they, or why wouldn't they use two identifiers? Yes, please.
So this just happened last week. A lot of us followed the nurse into the room, and the nurse said, "Oh, this is our patient. She dropped the IV, and he put it in the tube."
Can you start again, please?
Oh, the patient, or the phlebotomist followed the patient into the room, saying, "Oh, this is our patient." They put the order in on the wrong patient, so they went into the right room, but the wrong order.
Ah,
He didn't identify. He followed the nurse in.
I see. So he depended on somebody else.
Yeah.
Yes.
Yeah.
So, I mean, there is anybody else have any other examples that you want to share with us, how this could happen? Yes. Yeah, we'll have Twyla bring the microphone to you. But this is a really important point.
Where you are doing hourly labs on somebody and you
Yes.
think you recognize them. So you
Yes.
come back into the room and, oh yeah, that's the same person. And then
Yes.
you didn't know in between, they might have switched rooms.
Well, like Dr. Karen and I would say, muchos diablos como se parecen. A lot of devils look alike. There's devils that look like me. So I think we got to make sure, is that really Jim? So yeah, you have to be 100% sure. Don't assume anything, because people do look similar. Yes, please. We've got one right here.
When there's a code coming into the ER,
Yes.
usually they bring a code in, everybody's in there, you gotta run in there, you just go in and draw and just
Yes.
kinda get out and start running labs.
Yes, yes. So what do you do in that situation to make sure that you know who they are?
You usually ask the nurse or try to look at the computer or try to find something there because, talk to the
Yeah,
paramedic
yeah.
or the EMT.
It's a high-risk situation, but
Yeah,
you
'cause
still want to make
Usually the
sure.
patient's out of it and they're not banded quite yet.
Yes,
so they just get 'em right in
that's a
there.
risky situation. Yeah, thank you for bringing that. Any other examples anybody would like to share? Yes, please. When they're intubated, yes. So what do you do then? Family member or? So you have to, how do you know that that's their family member?
If they're in the room.
Okay, so you have to be 100% sure that they're identified correctly. Anybody else? Please.
One of the things that I'm sure that everyone else, I'm from Nowhere, USA. The freestanding emergency rooms are popping up everywhere. At least they are in where I come from. And I was hired as a consultant to take a look at their lab processes, and they didn't have an identification system at all. In fact, not the way we traditionally have it. In fact, I teach my students, I'm a community college instructor and I teach phlebotomy, and I make them check 3 ways. But in this way, when I went to the freestanding ER, since they don't have such a large amount of people as a traditional ER, you have them walking in and
Yes.
so forth. So what they do is they take the file, the chart, they'll put it somewhere, and then the person that's gonna go draw the blood knows that that person was there, and so they go to that room. But they don't ever check the names because they don't put the bracelets on.
Yeah, so there's a risk there.
No,
Because all it takes is one.
Yes.
And the wrong chart gets pulled, or the person, for some reason, identifies themselves wrongly. Yes, please.
If the patient is registered under the wrong name.
Yes, how does that happen?
It happened like a month ago. And registration registered a patient under the wrong name. They went into urgent care, had the bracelet on and everything. Nobody in urgent care identified the patient because they just looked at the bracelet and everything was done under the wrong patient.
So human error can happen somewhere else. That's a great point. I hadn't thought of that one, but thank you for sharing that. So there you can see there's a lot of ways that this can happen. In crew resource management, Reason said most accidents, including those in healthcare, are believed to be caused by careless individuals. That was before Reason. Now he says all humans are fallible, and you all gave great examples, and error rates could be diminished by focusing on the blunt end rather than blaming individuals. So that's why just culture is so important. We have to together say, what do we think went wrong? And let's be Columbo, and let's be a detective and figure this out. Several years ago, there was a flight, I still remember this, it was flying from San Diego to Minneapolis, and it got lost. I don't know what happened. They went wrong way. You see pilots land on the wrong runway, and you think, what the heck happened? I don't know what happened, but they lost their way, literally. And this is a good lesson. Some lessons can only be learned once. Ask that cat. So we can use crew resource management and phlebotomy. We can use team training and simulation. It's particularly helpful in places like labor and delivery, operating rooms, emergency departments, military medicine, and labs. Because we have a lot in common with those areas. We are tightly coupled. We're highly complex, just like the OR and ED in phlebotomy. So we have to be able to communicate really well with each other. And that's high risk. We don't have time to recover. So teams in laboratories share many of the same characteristics, and that's why it's so appealing. In Seattle Children's Hospital, they do the rounding, and they do briefs and debriefs. They figure out, this is what we're going to do in this situation, and then they debrief the situation. They said, this is what we learned from the situation. It's really helpful. I've seen that in action. It's used to achieve workload balance. It's part of a broader strategy of building healthcare teams. The goal is to prevent work overload, and it includes clear guidelines for what and how to delegate. So teams is really very important for all of us, and those who use crew resource management use so-called huddles, and their formal process improvement includes debriefs. So has anybody heard of an after-action review? Anybody with military training? What's an after-action review?
Well, you have your hot wash, and then your after action is you look at what went right, what went wrong, and what you need to do.
Great. Which system are you from?
I'm from Mayo.
Okay, great. So tell us about the after-action review.
So you have your hot wash first, where everyone that's involved gets together, and then what you do then is in your after-action report, you look at what went well, you look at what went wrong, and you look at the process that you can improve. Not so much the person,
Yes.
but you look at what went wrong as a team to make it better next time.
Oh, that's great. You made me so happy. That's exactly right. That is exactly right, because that's the after-action review. Because who hasn't made mistake? Every single person has made mistakes. So what's different about this? When we make a mistake, what's the thing we want to do? Run away, run, hide. Exactly. That's what we want to do, right? So in the just culture, crew resource management, after-action review, these all take courage, right? This is a different way of doing it. We have to have the courage to bring up these errors and say, you know, not that Jim made a mistake, but this is what I observed, and I think there's a hole in our system that we need to fix. So, are these people happy with each other? No, they're not. So, use of crew resource management in our institution involves teaching team members formal team building skills and barriers to team building, assertion skills and conflict resolution, even if we don't like somebody, especially if we don't like somebody, especially if they just rub us the wrong way. There's always somebody out there. Remember, perspective, perception, and the meaning we give things. We weren't all raised at the same kitchen table. People will approach us and will just, our shoulders will just be very tight. Everybody has somebody that is going to really touch our buttons, regardless, and that's where we really need to be saying, they're on my team. We don't want to punch them or poke them in the ribs, or especially in the eyes. So did you know that you could use cuss words at work? You can go back home and you can tell them, Dr. Hernandez told you can use cuss words. I am concerned. Because you don't have to say, hey, what about that? You know, and people are really polite in the Midwest. I really remembered that. In other parts of the country, if you see something, people will say it right away. For example, if I was going to take a screwdriver and I would stick it into a socket, in where I live, people would say, what are you doing? Here, people, right? Todd, people say, what would Todd tell me? Todd would say, you know, Dr. Hernandez, a lot of guys wouldn't stick that screwdriver in that socket. Because they don't, you know, very, very polite. And that's a lot of guys. This is equivalent to a lot of guys. You know, a lot of guys wouldn't do that. I'm concerned about that. Help me understand that I'm uncomfortable. This is a safety issue. Nobody can invalidate your feelings. I'm concerned, I'm uncomfortable. You're not saying you're doing it wrong. What you're saying is, I'm uncomfortable with what's happening. Help me understand the situation. Can I have some clarity? A signal to others in the team to pause before proceeding. Can I have some clarity? This lets others know that the team member wants to raise safety concerns. So any questions about crew resource management? Does that make sense? How about we're in the tail end and we're just going to go over a couple more skills, S-bar. Anybody use the S-bar? So several of you use S-bar. How about the hands of people who don't use S-bar? Who don't use S-bar? Well, let's go over S-bar. S-bar is another team building school, and this came from our nurses, and we use it in our situation. And the reason why is we want to make sure we have a clear, concise communication what went wrong. And so we adapted this from our nurses. It's a handoff communication tool. S stands for situation, patient name, location, etc. The background, what actions have you taken? What's your assessment, your team's assessment, and the recommendations. So this is the S-bar, situation, background, assessment, recommendations. A lot of times we ask people to do an S-bar, so this is a way we can communicate critical situations. That even on a handoff from one shift to the other, you can use an S-bar. It tends to make it less subjective when there's an error. An S-bar tool is used to communicate information for handoffs. Where do most of the mistakes happen? Handoffs. How about your shifts? That's risky, right? The shifts, because people may not be communicating. We use a tool to avoid critical miscommunications. So in summary, you can adapt the just culture, and I hope that that's been clear, the just culture. And you can also use tools like crew resource management and S-bar for your phlebotomy practice. And that's me celebrating in Arizona. So any questions from anybody? Anything was not clear or cases you'd like to share with us? Does this make sense? You think you'll be able to go back and use S-bar in your groups? How about those who have used S-bar? Have they been helpful? Anybody like to share a case of S-bar with a group so that those who are not use them? Yeah, please share that. Give us an example how you'd use an S-bar.
So with my lab, we sometimes get specimens that we get drawn that have to get sent down to the university, but then also sent out to ARUP.
Yes.
Or the Mayo.
Yes.
And so we use the form to then send it with the specimen to the university to, after they're done testing, to have them do what needs to be done to get it out to ARUP or the Mayo.
Very
so
good.
that it doesn't get lost in testing.
What is the effect of the S-bar on your team?
It's really good.
Okay.
We do like it because it is something that, a lot of times you don't have that time to pass off things as well. Within, people coming in late, or maybe you had to leave early.
Yes.
It is definitely a good thing to you can jot it down, especially if you, like me, I don't have a great memory all the time.
I'm with you.
So it is good, I can jot it down right away, so I know, put it aside. You have so many patients that you deal with, and you're not always going to remember every little detail.
Yes.
So it is, I really enjoy it. It's something that I know that when I'm passing off my workload, that it is definitely going to be taken care of.
Thank you for sharing that. That was a great story. I just figure, why didn't we have this when I started? It's so good. So it's an elegant tool, and you can use it. You can't overuse it. Just keep it concise and clear. And it's as if you're telling a friend, I want to keep you out of trouble. I want to protect the patient. Here's the information. Please, please share this.
Before I was a phlebotomist, I worked as a HUC. And we had kind of the same thing. We didn't call it S-bar, but we would have, like, for the nurses, changing shifts when they did the handoff. So we would know what med the patients were on, what their diet was.
Yes.
So we kept track of that, and I used to have to put those together. But we didn't call it S-bar, but it's very similar to this.
Very good.
Yeah.
Thank you for sharing that. What other things did you learn? Please.
I
Well, I know the nurses liked it because it wasn't so much a nurse telling a doctor about their patient, or if we made a mistake, there was no blame. If they would catch something on an off shift,
Yes.
they'd send the SBAR, and it caused a better relationship, I think, between all of us.
Good point, because sometimes we can see the nurses as not getting it, and sometimes the nurses can say, the people in the lab don't get it. Yeah, so let me tell you a story what happened. You know, this is with our good Rochester crew. This was years ago when we had, and some of you remember this example, years ago, the nurses were cutting off the wristbands. Do you remember that, Dr. Karen? They were cutting off the wristbands. And the natural reaction for us in the lab was to say, what's wrong with those nurses? Why are they cutting off the wrist? Don't they know what the bad impact that'll be? And I said, well, why don't we go to the nurses and ask them why they're cutting off the wristbands? So we talked to them. Remember, we got together in a group, and we talked to them, and he said, you know, we're aware that some wristbands are being cut off. Can you tell us why? And they had good reasons. Remember, the nurses are protecting the patients. One of them was babies. The wristbands were hurting the baby's wrists and making them cry, and they're relieving the suffering by cutting the wristbands, putting them on the gowns, not realizing this is not good. It's not the way we identify. The other situations, do you remember what that might have been? It was obese patients and edematous patients. And so we came up with solutions together with the nurses. They have some soft pediatric wristbands that now we use, and also there's some expandable wristbands for the edematous and obese patients that we can use it so they don't have to cut them off. But that was a collaborative solution, but I think the laboratorians could understand the nurse's point of view, and the nurses could understand the laboratorians. They may seem distant, but they're really involved in patient care. They want to do the right thing too. So it was a good win-win for our organization. Any other comments or questions? If not, thank you very much. I've really appreciated the opportunity to speak to you this morning.